Good evening, consultants, fellows, and colleagues on the call. You are welcome to today's meeting. Today we have a presentation by our colleague, Dr. Sori, on special anti-ischemic drugs. Dr. Sori, please, your audience.
Good evening, teachers, colleagues, and facilitators. I'm Dr. Sarah. I'll be taking the topic anti-ischemic drugs with concentration of ivermectin, nicorandil, ranolazine, betazidine, and their indications. So, as a way of introduction, the anti-ischemic drugs are drugs employed for the control of myocardial ischemia in patients with stable ischemic heart disease or chronic coronary syndrome. The first line of initial drug therapy for management are the short-acting nitrate, beta blockers, and or calcium channel blockers. The anti-ischemic or long-acting agents can be added on top of a beta blocker and or a calcium channel blocker as part of initial combination in appropriately selected individuals or patients. So the next slide, please. So the next slide is just a table indicating all the various kinds of anti-angina medication from nitrates, examples, beta blockers, the examples, calcium channel blockers, as well as the newer medications or the novel medications and their examples. The next slide, please.
Hello?
The next slide, please. Okay, this is another table for a possible combination of the anti-angina medications, combination of both the first line and the novel anti-ischemic medications. Some of them you can combine, and there are different medical conditions, and some that are of serious contraindications that you may not be able to use. So in our leisure time, we can go through. There's a different colors of lines that you may use to ascertain the usefulness of them and the ones that are both recommended and not recommended. So the next slide. In the next slide, I will just be talking about or refreshing our mind on action potential of both the SA node and the cardiac myocyte, because this will build on most of the anti-ischemic drug, the novel anti-ischemic drug, because their pathophysiology or their making of action center around some of these key points. So on the action potential of the SA node, this action potential, it has been discussed by one of our colleagues when she talked about the heart as a pump, but I'll just give a brief overview, just a few slides so that we can move together at once. So for the SA node action potential, it's the resting membrane potential of the synode fiber is about -60, while for the ventricular muscle mass is more negative. Let's note that the SA node is less negative because of the leakiness of sodium and calcium during the repolarization phase. At the end of each impulse, potassium begins and brings about repolarization. Potassium then declines and a channel permeable to both sodium and potassium is activated. Because this channel is activated following hyperpolarization, it is referred to as the H channel or the HCN channel, also known as a Fonny channel. If the Fonny channel increases, the membrane begins to depolarize, forming the first part of the pacemaker potential, and this causes the calcium channel, which causes the calcium channel to open. If I may just do a little explanation on that, if we look at the upright, that schematic there, other slides, I'll have some other schematic to also explain. The red lines there, those are the action potential of the SA node. What this slide is just explaining is that we look at that straight line, the horizontal line, that is the resting membrane line. So when there is the SA node, the depolarization of the SA node starts with that phonic current channel that is opening. That's why on SA node action potential, the SA node action potential in comparison to the cardiac myocyte, the SA node, the depolarization in the SA node is being fired by the resting potential. That resting potential, that is where the phonic current is situated. That's why the SA node, it's not actually the difference between this and the myocyte is that it does not usually come to that resting phase. It does not rest in relation to the cardiac myocyte. So as soon as there is repolarization, that repolarization activates the HCN channel, which is the H channel that as discussed in the slide. It activates that HCN channel, which HCN receptor, which is a hyperpolarization activated cyclic nucleotide gated receptor. In activating that HCN receptor, it opens the phonic current. And that phonic current causes a leaking or influx of both sodium and potassium back into the SA node or the cell. When it leaks in, that causes an upsurge again, a slow depolarization. I wish I have my cursor. I would have been talking with that cursor. So there will be slow depolarization at that point where you see an arrow of stated without resting potential. So when the phonic current opens, there will be slow leakiness of sodium and potassium back into the cell, causing a slight surge of depolarization. At a point, it is completed by the transient calcium channel, which pushes it to the transmembrane potential, and a surge of the long calcium channel opens in the membrane, causing influx of calcium, which causes the rapid depolarization, getting to the peak, and potassium channel opens, which causes repolarization again. So this is exactly what happens in the SA node. That phonic current that causes that first resting potential, that phonic current is where ivabradine blocks. So when we get to ivabradine, we understand why ivabradine has that propensity of reducing heart rates. Let's go to the next slide, please. So this is the action potential of cardiac myocytes. In comparison to, okay, this is just a completion of what I said earlier. So calcium current due to the opening of the T channels completes the pacemaker potential, and that due to opening of the lung channel produces the impulse. Action potential in the SA and AV nodes are largely due to the calcium ion. Atrial and ventricular muscle fiber do not have pacemaker potential, and they discharge spontaneously only when injured and or abnormal. Next slide, please. Okay, this is the action potential of the cardiac muscle cell. This is different from the cardiac action potential that happens in the SA node. In this, you have different phases. And in this, there's a clear resting membrane potential, unlike the SA node, which do not actually have a resting membrane potential. In the SA node, as the repolarization takes place, that repolarization or hyperpolarization activates the HCN receptor, which opens the phonic current and starts another level of depolarization. Unlike this, there's a resting membrane potential which equalizes the ions in the intracellular and extracellular space, which activates phase 4 of action of the cardiac muscle. So in this, when the action potential initiated by the SA node travels along the conducting system. The previous slide, please. Dr. Eugene, please go back to the previous slide so I can just read through. So the action potential initiated by the SA node actually travels along the conducting system and spreads out to excite the atrial and ventricular muscle fibers. So I said there are 5 different phases. The rapid depolarization phase, which is the phase 0, the initial rapid repolarization phase, which is phase 1, the plateau phase, slow repolarization, which is being taken care of or being activated by the delayed rectifier potassium channel, and also the resting membrane potential. The initial depolarization in the cardiac muscle cell, it's being activated by influx of sodium. So influx of sodium causes that initial depolarization, that sharp depolarization, which is phase 0. Note that at that point where sodium current is being moved into the intracellular space, the calcium channels also open, but at that point, the calcium channels open slowly, but the sodium channels open faster and rapidly. Hence, that surge of depolarization till it gets to a peak. Note the difference between this peak, where the peak of the depolarization before it gets to the plateau and starts coming down. This is at plus 20 in cardiac myocyte, unlike the action potential in the SA node that strikes up to about plus 20, plus 10 before it gets to a peak. The calcium channel closes, the potassium opens, and there's repolarization. But in the cardiac myocyte, it peaks at about 20. At that point, when the sodium surge comes in and there's influx of sodium, it peaks at about plus 20. Then the sodium surge starts closing slowly. At that point, potassium channel opens. When potassium channel opens, there is now leakiness of potassium outside the cell. There's now an efflux of potassium and slow entry of the sodium. That causes that phase 1 in the action potential curve. And remember, I said when the sodium is being opened at the initial phase, calcium opens at the same time. This leads to calcium channel opening more rapidly at the phase 2, which causes the plateau phase. At almost the end of the plateau phase, when calcium channel opens, there's leakiness of calcium into the intracellular space. The potassium channel starts opening slowly. And when the calcium channel opens to where there's end of contraction, the potassium channel starts opening, and there will now be efflux of potassium. So at this point, the efflux of potassium causes that repolarization. There are different kind of potassium openers at that point that causes that repolarization before it gets to the baseline. We have the ultra rapid, we have the rapid and the slow. So the opening of the delayed rectifier potassium channel causes the phase 3, which is the repolarization phase. So everything on this slide is what I've been talking about. The initial depolarization is due to sodium influx through rapid opening of the voltage-gated channel. Within a few milliseconds, the fast sodium channels open automatically and inactivate, and sodium flow decreases. The inactivation of sodium channel contributes to rapid repolarization, which is the phase 1. While calcium influx through the pores slowly more slowly opening calcium-gated or voltage-gated calcium channels produces the plateau phase. Repolarization is due to potassium efflux through the multiple potassium channel, as I said. Please, the next slide, Dr. Lee. So this, I put in two different, the cardiac myocyte and the pacemaker, the cardiac myocyte and also the SA node, so we can look at the major differences between them. The major differences between them is that one, the myocytes in the cardiac myocyte, it has a resting membrane potential and it can completely rest at a time. And that particular phase of that resting phase is phase 4. And that phase is usually controlled by the sodium potassium pump. There's a sodium potassium ATPase there. But in comparison to the SA nodal pacemaker cells, there is no time it has a complete rest. As soon as potassium channel opens when repolarization starts, it gets to a point. As I said, the repolarization and hyperrepolarization activate a receptor called the HCN receptor, which opens the funny current channel, causing slow leakiness of sodium and potassium, activating another phase of depolarization before the slow calcium channel or the transient calcium channel takes over from them, hitting the transmembrane level and is upsurge of calcium. So in the SA nodal pacemaker cell, what causes depolarization? The influx of calcium. Unlike in the myocytes, what causes the upsurge is influx of sodium. And also in the cardiac myocyte, there's the calcium, in the cardiac myocyte, the job of the calcium there is to cause contraction, which is the plateau phase of stage 2 of phase 2, unlike the SA nodal pacemaker cells, which do not have that plateau phase. Both of them, repolarization is being controlled or brought upon by efflux of potassium. So next slide, please. So if we look at the cardiac myocyte, the picture to your right, you see on that phase 1 and 2, that is the major point where contraction takes place. As soon as calcium enters into the cell, that calcium causes release of more calcium that calcium that enters into the cell causes activation of ryanodine 2 receptors in the sarcoplasmic reticulum, which causes upsurge of calcium into the cell and activating the troponin and tagging with the troponin C on the actin, causing contraction. So at this phase of the action potential in the myocyte, that is where that calcium influx that enters into the cell, causing the plateau phase, is that calcium influx that activates another calcium in the cytosol from the sarcoplasmic reticulum to cause excitation contraction coupling. So let's note at this point that it is not the calcium that activates this, that causes this plateau phase, that goes to the actin. This calcium enters into the cell, goes into the activate the ryanodine receptor, which causes efflux or push of calcium from the sarcoplasmic reticulum back into the cytosol to attach to the actin, which causes excitation contraction. At this phase, this is where ranolazine inhibits. Once ranolazine inhibits this phase 1 and phase 1. Once it inhibits this phase 1, there won't be influx of sodium. That's rapid sodium that enters at that before the calcium comes at that plateau phase. Once ranolazine inhibits that, calcium will not be able to enter into the cell at that point. There will be a total short of intracellular calcium. There won't be more calcium inside the intracellular cell to activate the ryanodine receptors, which cause upsurge or surge of calcium from the sarcoplasmic reticulum into the cytosol to activate actin. So this is where ranolazine acts at that phase 1. The next slide, please, Dr. Eugene. So the next slide just summarizes what I've been saying. Calcium is a central regulator of cardiac contraction and relaxation. Relatively small amount of calcium enters and leaves the cardiac myocyte during each cardiac cycle, with larger amount being released and taken back up by the sarcoplasmic reticulum. Each atom potential deprivation travels down the T tubules, and they open the voltage-gated L, which is the L-type calcium channel near the junctional sarcoplasmic reticulum, and activates the sarcoplasmic reticulum calcium release channels. A small amount of the calcium entering via the calcium currents triggers release of larger amounts of calcium into the cytosol. In the human ventricles, sarcoplasmic calcium release is 3 to 4 times higher than the calcium influx by the lung calcium channels. The combination of calcium release and influx elevates the calcium and promotes binding of calcium to troponin C, and thus contraction ensues. So we can still study this schematic by the right. This is exactly what I've been explaining. The ryanodine receptor is that the first calcium enters. When calcium enters into the cell, activate the ryanodine receptors, which causes upsurge of calcium from the sarcoplasmic reticulum into the cytosol to attach to troponin C on the actin, causing contraction. When most of the calcium from this sarcoplasmic reticulum, when more than 50% have exited or have been pushed out of the sarcoplasmic reticulum into the cytosol, this causes a reversal of the calcium. So once it gets to less than 50% calcium out of the sarcoplasmic reticulum, it goes back into it takes back calcium into the sarcoplasmic reticulum. That causes relaxation. So most of the calcium that attaches to the troponin C causing contraction goes about 75%, goes back again to the sarcoplasmic reticulum, which is aided by the SACA2 receptors, which is sarcoplasmic endothelial reticular calcium ATPase. So about 75% goes back, while the others are taken back by X to the sodium calcium extension. So the next slide, please. So let's go to the specifics, ivabradine. So ivabradine, we can just, there are some little mnemonics that are used in ivabradine to try to remember some of these things. When looking at the name, the I in ivabradine, we remember that let's remember with the first I, it is an ion channel. So the mechanism of action is through an ion channel, which is the phonic currents. The V and A that follows is one of the major side effects. Some of the major side effects are with the alphabet V and A. V, they usually come up with visual disturbances, while the A, they come out. One of these major side effects, atrial fibrillation. Brad, of course, they slow down the heart rate and they can cause bradycardia. So we can just pick out some of the alphabet and remember some of the major things from ivabradine. So it's a specific and selective inhibitor of the phonic current ion channel. The principal determinant of sinoatrial node pacemaker currents. An important current involved in generating the early phase of the spontaneous diastolic depolarization, reducing the frequency of action potential. It was approved by the European Medicine Agency, EMA, in 2005, but by the FDA in 2015. The supporting trials that done with ivabradine, the Beautiful trial, the Shift trial, and also the Signify studies. Next slide, please. Ivabradine is used in patients with symptoms due to stable heart failure and an ejection fraction less than 35 or less to reduce their risk of hospital admission for worsening heart failure. Patients on ivabradine therapy should have a resting heart rate of at least 70 beats per minute and must be in normal sinus reading. They should also be on their maximal tolerated beta blocker or have a contraindication to beta blocker use. In Europe, ivabradine is indicated in the treatment of heart failure and chronic stable angina. The Shift trial, as I said earlier, was a double-blinded, placebo-controlled ivabradine. Sorry, the Shift trial was double-blinded, placebo-controlled ivabradine, which reduced the primary endpoint, which was the composite of hospital admission due to heart failure and mortality. Next slide, please. So the Beautiful trial was a randomized, placebo-controlled, multinational trial to test whether reducing heart rate with ivabradine affected cardiovascular morbidity and mortality in patients with coronary artery disease and EF less than 40%. Ivabradine did not affect the primary composite endpoint of cardiovascular mortality, hospital admission for myocardial infarction, or worsening heart failure. In patients with heartbeats of 70 or greater, ivabradine reduced hospital admission due to fatal or non-fatal myocardial infarction. For the Signify study, it was a randomized trial that tested the addition of ivabradine to standard therapy in patients with stable coronary artery disease, but no heart failure. There was no significant difference between ivabradine and placebo. So this slide is just a slide that captures the trials that was done with to confirm ivabradine use. The Beautiful trial, which was done in 2008, the Shift trial in 2011, and the Signify trial in 2014, and also the time of approval by the American European Medicine Agency and also the FDA in the USA by 2015. Next slide is the mechanism of action of ivabradine. So as I stated earlier, the mechanism of action of ivabradine is blockade of the phonic current channel. So it blocks the channel responsible for cardiac pacemaker current, which is the phonic current ion, which regulates heart rates. This results in prolonged diastolic time and reduced heart rates. Rapid resting heart rates can lead to detrimental effect on ventricular function and has been associated with negative outcome in patients with cardiovascular disease. Ivabradine reduces heart rate but does not affect myocardial contraction, relaxation, or ventricular repolarization. So you should take note of this. Ivabradine just as it blocks the phonic currents, and its job is just to reduce the heart rate. It does not have anything to do with calcium interaction, so it does not affect myocardial contraction. Unlike ranolazine, when I go to ranolazine blocks sodium, thereby affecting influx of calcium, causing less contraction. So ranolazine, ivabradine just reduces heart rates without affecting contractility. It reduces the peak heart rate during exercise, increases the time to limiting angina when compared with placebo, and equivalent to atenolol with respect to exercise performance and time to ischemia in stable angina patients on treadmill testing. So this is just a schematic to show where ivabradine blocks the phonic current and how it reduces heart rates. You see both of them. The first control is the normal action potential of the SA node, but when ivabradine blocks at that early phase where the resting potential comes in, it causes heart rates to be reduced. So next slide. Of note in this slide is to show that ivabradine, it blocks the HCN receptor. As I said earlier, the repolarization caused by efflux of potassium causes repolarization, and the hyperrepolarization activates the HCN receptor. The HCN receptor is the hyperpolarization activated cyclic nucleotide gated receptor. That receptor harbors the phonic current or causes the phonic current to open, through which the sodium and potassium leaks through. Ivabradine blocks that receptor or the phonic current channel, and of note that it blocks it from the intracellular side of the cell rather than the extracellular. So you just see that green ball on the intracellular side, signifying that the blockade by ivabradine is from the intracellular aspects of the cell rather than the extracellular aspects. Next slide, please. So for the administration of ivabradine, it's available as tablets to be taken by mouth. The initial dose is usually 5 milligrams twice daily. The dose can be adjusted after about 2 to 4 weeks based on the heart rates. The maximum tolerated dose is 7.5 milligrams twice daily. Patients with conduction defect or bradycardia can be initiated on 2.5 twice a day. The reduction in heart rates depends on the baseline heart rate and ivabradine dose. Next slide, please. So the next slide is still like what I've discussed earlier. Normal starting dose, as I said, is 5 milligrams. And after about 2 to 4 weeks, you can reassess with the state of the patient and the pulse rate or the heart rate. If the heart rate is more than 60 beats per minute and you start at 5 milligrams, you can up by 2.5. Keeping in mind that the maximum tolerated dose is 7.5 milligram BD. But if the heart rate is 50 to 60, you maintain at the initial dose you start with to continue monitoring this patient. While if the heart rate is less than 50, you decrease by 2.5 milligram BD. So the next slide is on the adverse effect. The most common adverse effect is bradycardia. As I said, in the name, you remember there's brad there. So that brad can be remembered as bradycardia. So there will be bradycardia. In the name also of ivabradine, there's A, as I said earlier, atrial fibrillation. It could lead to high blood pressure, and phosphanes. Phosphanes are visual disturbances that can be seen by some of these patients. As I said, the V in ivabradine can be remembered as it causing one of the major side effects, which is visual disturbances, which is phosphanes. This phosphanes it occurs by blockade of that phonic current, or blocking the HCN receptor in the photoreceptors in the retina. This brings about these phosphanes as a side effect. Ivabradine can cause sinus arrest also, heart block, sinus node dysfunction, various degrees of atrioventricular block, bundle branch block, ventricular dyssynchrony, and others. Ivabradine is metabolized by the cytochrome P450 enzyme and other drugs that's also metabolized by that cytochrome P450, like the verapamil and diazepam, should be avoided with use of while using ivabradine, because they could increase the level of ivabradine in the blood or in the blood, hence exaggerating the side effects of these drugs. Other side effects are QT prolongation, tossing the point, and also other arrhythmias that could be induced by ivabradine. So the next slide, please. The next slide is just a list of drugs. We can go through them in our leisure time of drugs we should avoid while using ivabradine, because these drugs, they could be strong, moderate to strong inhibitors of the cytochrome P450 CYP3A4 enzyme. So we should take care while administering these drugs with ivabradine. Next slide. I've talked about other things in the next slide. Talked about the visual effect that comes with it. Ivabradine has also been shown to cause fetal toxicity in animal study, while post-market adverse effect was also noted in some patients. These post-market adverse effect, they are not side effects that actually seen while producing the drug. These are effects that were seen while the drug were already in the market, and the percentage of persons that this particular side effect have been seen are very, very minimal. The next slide. The contraindications to the use of ivabradine when blood pressure is less than 90/50, when there's conduction abnormalities, severe liver impairment, patients already on cytochrome P450 inhibitors, while resting heart rate of less than 60 before initiation of therapy. Next slide. So the next is the next anti-ischemic drug, nicorandil. Nicorandil also is one of the special anti-ischemic drugs. I also try to remember some of these drugs or their mechanism of action with the name. So the N in nicorandil, remember that it can cause release of nitric oxide, which causes vasodilatation. While most of these drugs, usually when I was reading in the past, I always find a way to remember the mechanism of action. So for nicorandil, I try to remember with the Nic, C. I pronounce the Nico with the C. I replace it in my brain with K. And that tells me, it makes me remember that the mechanism of action is from an ATP-sensitive potassium channel. So when I remember nicorandil with the C as K, I remember potassium, then I know that it opens potassium channels. So it is a nicotinamide ester that dilates peripheral and coronary resistance vessels via action on ATP-sensitive potassium channels and possesses a nitrate moiety that promotes systemic venous coronary vasodilatation. It's an anti-anginal. Its anti-anginal property have been known for over 30 years and are approved for medical use in 1983. It reduces the risk of cardiac death, myocardial infarction, hospital admission for angina in comparison with placebo when added to the standard anti-angina therapy. The next slide. Nicorandil is a well-known anti-angina agent which has been recommended as one of the second-line treatments for chronic stable angina. Comparative clinical trials have shown an equivalent efficacy in improving effort angina and ischemic symptoms compared to beta blockers, calcium channel blockers with minimum hemodynamic disturbance. Moreover, nicorandil intake has not been associated with significant drop in blood pressure when used with calcium channel blocker or the beta blockers. It acts as an efficient anti-ischemic agent in patients with contraindications to use of beta blockers such as bradycardia and exacerbated pulmonary diseases. Next slide, please. The next slide is on the pharmacology of nicorandil. As I said, is an opener for adenosine-sensitive ATP-sensitive potassium channel with a nitro-vasodilator effect, which is a donor of nitric oxide. Several mechanisms have been proposed for its cardioprotective effect because it has different uses. Nicorandil has different uses or different ways it protects the heart. So by one, it protects the heart by improving myocardial blood perfusion, also by reduction in preload and afterload. It's said to protect ischemic damage. It has anti-arrhythmic effect. It also prevents calcium overload. It has energy modulating action, and also has anti-inflammatory, anti-apoptotic, and anti-proliferative effects. So nicorandil produces its effect by dilatation of the coronary arteries and by reduction of the myocardial oxygen demand, mainly by affecting afterload and to a lesser extent the preload, ultimately reducing the left ventricular end diastolic pressure. It is considered a balanced vasodilator, which affects both the arterial and the venous system. The effect of nicorandil on preload may be less than that observed with nitrates due to the significant decrease in systemic vascular resistance, which tends to increase venous return. So the next slide. Nicorandil is known to activate specific receptors. The receptor is activated the KIR6.2 sulfonylurea receptor 2A and 2B, which confirm its specificity for ATP-sensitive potassium channels of both the calcium and the smooth muscle respectively. Let us note that the SUR2A is specific to the cardiac muscle cells, while the SUR2B is specific to the smooth muscle cells. Most of the action of nicorandil, even if its mechanism of action is to activate both receptors, but most of the activity of nicorandil is centered on the SUR2B receptors, which is more on the smooth muscle cells. In addition, nicorandil shows no observable effect on insulin secretion, which is consistent with its lack of effect on the SUR1 current, revealing its good tolerability in diabetic patients. And the next slide is the next slide is just giving us the broad two mechanisms at which nicorandil causes vasodilatation of the vascular smooth muscles. Next slide. Next slide is on the next slide, please. Okay, so the next slide is just on the further on the pharmacology. The elimination half-life is about 1 hour. The tablet of nicorandil usually comes in 10 milligram as a 10 milligram tablet with a dosage of 20 milligram per day, but can be stretched up to 40 milligram per day. The starting dose is usually 10 milligram BD, so it should be given in divided doses. And it's classed on category 3. Category B3 in the pregnancy categorization, and this drug should be avoided as much as possible unless considered by the physician. The next slide is on the protective effect of nicorandil on as it regards the mechanism, the two mechanisms of action. For the ATP-sensitive potassium channel, opening effects has various protective effects on the heart. So the usual dose we give has more effect on the cardiac and the pulmonary system, while most of the time the supranormal dose has more effect on any donation, which is more on the bowels. So you see to the right, the any donation, the protective or curative effect is more on hepatic fibrosis, inflammatory bowel disease, and male potency. But on the ATP sensitive potassium channel, from that channel is more on a cardiac protective against cardiac fibrosis, pulmonary fibrosis, and so on. Next slide. The next slide is on the side effect of nicorandil. Its side effects are minimal, including headache as a common side effect, in addition to less common side effects such as palpitation, dizziness, flushing, vomiting, perineal, ileal, and peristomal ulcerations, and malaise. Nicorandil is contraindicated in the setting of hypotension, left ventricular failure, hypovolemia, acute pulmonary edema, or concomitant with other vasodilators. So next is ranolazine. As I said, most of these drugs, we try to remember the mechanism of action with the names. As I also try to code it then, ranolazine, because most of these drugs, it gave me a little headache back in the days on how to remember the particular channel they block. So for ranolazine, the end there, once I see the N in ranolazine, I try to remember sodium. So it blocks the sodium channel. So I try to remember ranolazine with that. Once I see N, I remember sodium channel, NA. So ranolazine is a piperazine derivative that was approved in 2006 in the United States for its use in patients with chronic stable heart failure, chronic and stable angina. It has also been suggested to reduce procedural myocardial damage or injury in patients undergoing elective PCI. Ranolazine decreases angina frequency and nitroglycerin use when used in conjunction with beta-blocking agents or calcium channel blockers. It is a second-line anti-angina medication based on different trials that supported ranolazine use: the MARISA trial, the CARISA trial, and the ERICA trial. Remember, the Vibrato, we talked about the Beautiful trial, the SHIFT trial, and the SHIFT trial and the Signify trial. But in ranolazine, we'll talk about the MARISA trial, which is a monotherapy assessment of ranolazine in stable angina patient. The CARISA trial, which is a combination assessment of ranolazine in stable angina. This combination assessment, it's with the randomized ranolazine, atenolol, amlodipine, or diltiazem. So that is the CARISA trial, while the ERICA trial is testing the efficacy of ranolazine in coronary artery disease. Next slide, please. Okay, the next slide is on the mechanism of action. The mechanism of ranolazine anti-angina and anti-ischemic effect is not entirely understood, but it is known to inhibit the late phase of inward sodium channels in the ischemic cardiac myocyte, reducing the intracellular sodium concentration and thus reducing intracellular calcium influx in the sodium-calcium channel, thus resulting in reduced contractility and also reduced oxygen demand. As I said, if you remember, I think I still put one of that action potential of the cardiac myocytes here when I said the mechanism of action is to block that phase one, that sodium influx. Once it blocks the sodium influx, at the same breath, it blocks the calcium influx. And once it blocks calcium influx, there will be no calcium available in the cytosol to activate the ryanodine receptor to bring about contraction. So at that time, with this mechanism, it reduces contractility. Next slide. So the decreased intracellular calcium reduces ventricular wall tension and thus reduces oxygen consumption. It does not affect blood pressure or heart rate. The drug that affects heart rate more is ivabradine, which blocks the phonic current. At higher concentration, ranolazine inhibits rapid delayed rectifier potassium current, delaying atom potential and prolonging QT. So at higher concentration of ranolazine, it also inhibits those delayed rectifier potassium channel, thereby prolonging repolarization and causing QT interval prolongation. Ranolazine also inhibits fatty acid oxidation, which enhances glucose oxidation, reduces lactic acid production with less intracellular acidosis, and improves heart function by reducing the severity of myocardial ischemic response. Actually, how this is another mechanism by which ranolazine is also useful in patients with stable angina. This is the same mechanism of inhibition of fatty acid. This is one of the major mechanisms. The next drug, which is the trimetazidine, also uses as its way of having useful effects in patients with chronic coronary syndrome, because fatty acid, the heart muscles usually use fatty acid and glucose as their major means to generate ATP for its use. But it favors fatty acid more because fatty acid contain more calories per gram than glucose, which is then it is even problematic when the heart is not receiving enough oxygen due to atherosclerosis, because the heart favors fatty acid more. So when there's atherosclerosis, the heart needs more oxygen, which fatty acid may not be able to help the heart with at that point in time. So during such situations, glucose is now a better substrate, a better substrate to produce ATP for the heart muscles. That's why ranolazine, once it inhibits fatty acid oxidation, it enhances glucose oxidation, which uses less oxygen to produce ATP. So the next slide is, okay, I've presented this slide earlier. Ranolazine blocks, if you see where the plateau starts from phase 1, ranolazine blocks that sodium influx. Once it blocks that sodium influx, at the same breath, it blocks potassium influx. Once it blocks, it blocks calcium influx. Once it blocks calcium influx, there will be no calcium available for you to activate ranolazine receptor to produce more efflux of potassium, of calcium, from the sarcoplasmic reticulum to attach to troponin C to cause excitation contraction, hence contraction of the heart. So once ranolazine blocks the sodium, it reduces contractility. The next slide. On the pharmacokinetics, absorption of ranolazine, ranolazine time to peak concentration varies between 2 to 6 hours with steady state achieved within 3 days of twice daily dosing. Ranolazine steady state volume of distribution ranges from 85 to 180 liters. The drug is rapidly hepatically metabolized primarily by CYP3A4 enzymatic activity. Minor metabolism occurs through CYP2D6. Thus, the plasma concentration is increased if administered in combination with other drugs that inhibit this system. Elimination, 75% of the drug's of the administered dose is excreted renally, with the remainder excreted in the feces. The drug has a half-life of about 7 hours. The next slide, please. We'll be rounding up very soon. We're entering the last drug. The dosing should begin at 500 milligrams twice daily. We've seen people that usually make some mistakes in prescribing this drug as a daily dosing drug. It's actually all the studies favor the twice daily. So the correct dosing of this drug usually a twice daily dosing medication that can be titrated to 1,000 milligrams twice daily as tolerated. The maximum recommended is 1,000 milligrams twice daily, although some studies pushed up to 1,500. The tablets are film coated. It should not be crushed, broken, or chewed. Food does not alter the absorption rates or the area under the plasma concentration time curve. Ranolazine can be administered without regard to meals. So the side effect, the next slide, the side effects of ranolazine can range from dizziness to headache, nausea, confusion, tinnitus, vertigo. The next slide, please, Dr. Eugene. Sorry for stressing you. Blood vision, dyspnea, palpitation, abdominal pain, dry mouth, vomiting, and other gastrointestinal complications or adverse effects. More severe adverse effect is on the QT prolongation by blocking the delayed rectifier potassium channels. And it can also cause syncope, hematuria, bradycardia, hypotension, orthostatic hypotension, thrombocytopenia, leukopenia, angioedema, renal failure, eosinophilia, pulmonary fibrosis, and pancytopenia. Concomitant use of ranolazine with metformin increases metformin level and has been found to reduce HbA1c by 0.43%. Monitor blood glucose and adverse effects of metformin in this patient is advised. The last drug is the trimetazidine, which is popularly known, which the popular brand we use in this part of the country or in Nigeria is Vastarel. Trimetazidine is, the IUPAC name is 1,2,3-trimethoxybenzylpiperazine, and it's a drug sold under many brand names for angina pectoris. Although documented clinical experience is limited, it has been approved in Europe in 2012. It is an anti-ischemic metabolic agent of the fatty acid oxidation inhibitor class. It improves the heart muscle ability to use glucose as a fuel by inhibiting its use of fatty acid metabolism, as I explained in the previous slide. So it inhibits fatty acid metabolism, favoring glucose metabolism, which uses less oxygen in times of atherosclerosis. Next slide, please. Trimetazidine increases coronary flow reserve. It limits rapid swing in blood pressure without any significant variation in heart rates. It significantly decreases the frequency of angina attacks and leads to a significant decrease in the use of nitrates. The usual dosage is 35 milligram BD for the modified release or 80 milligram for the prolonged release daily administration, usually with meal. The next slide, I think the next slide is just a summary of what I've said earlier, the mechanism of action, which I said inhibits beta oxidation of fatty acid by blocking long-chain 3-ketoacyl-CoA thiolase with the effect of enhancing glucose oxidation. The other things here I've talked about in the previous slide. So next slide, the precautions with the use of trimetazidine. Next slide, please. We should be cautious while using a drug in pregnant persons, breastfeeding mothers, kidney disease or end-stage renal disease or kidney or EGFR less than 30 mils, patients with Parkinson's disease and other movement disorders. Next slide has some major side effects like gastrointestinal upset, like nausea, vomiting, diarrhea, abdominal pain, indigestion, can also cause headache, dizziness, and movement disorders. So the next slide is the ESC 2024 guideline for management of chronic coronary syndrome, centering on these 4 major medications. So for the general strategy in recommendation of anti-angina medications, the general strategy 1 for class A, I didn't go into the level of evidence and classes. I think with so many presenters have talked about what the classes level of evidence and the classes are. So for general strategy, it is recommended to tailor the selection of anti-angina drugs to the patient characteristics, comorbidities, concomitant medication, treatment tolerability, and underlying pathophysiology. Also considering local drug available. So that's class 1A. A patient with chronic coronary syndrome, you must put so many things into consideration before starting the medication. So it is not just knee-jerk that a patient with chronic coronary syndrome, you must start with a beta blocker or a nitrate. You must put so many things into consideration. It's a strong one, which is the class 1 level, and class 1 recommendation and level of evidence is C. For selecting these anti-angina medications, we start with short-acting nitrates. Short-acting nitrates are recommended for immediate relief. And also the initial therapy with beta blockers or calcium channel blockers to control heart rate and symptoms is recommended for most patients with chronic coronary syndrome. It is a class 1 evidence and class 1 recommendation with evidence B for both of them. So patient presenting with chronic coronary syndrome, your first to go drug should be at least the short-acting nitrates and beta blockers before you think of other things. Next slide. Okay. If these angina symptoms are not successfully controlled with the initial treatment or with beta blockers or combination, the next medication you go to from the ESC guideline is ranolazine or long-acting. So ranolazine comes in first. Ranolazine is class 2A recommendation B. So ranolazine comes first. So ranolazine should be considered as add-on therapy in patients with inadequate control of symptoms while on treatment with beta blockers and or calcium channel blockers, or as part of initial treatments in properly selected patients. Properly selected patients. When long-acting nitrates are prescribed, a nitrite-free or low nitrite interval should be considered to reduce tolerability. Okay, this is just saying that when you use a nitrate or a long nitrate medication in managing this patient, you must give, at least some books will tell you, close to 10 hours nitrate-free period. So if you are giving a nitrate drug that is maybe BD or TDS, at least you should give the evening dose should be like 6 p.m. so that patient can have a long time of nitrate-free to the next morning. So that's what this last point is just giving. It's just telling us. The next slide, please. I'm rounding up now. I have a few, like two or less slide left. Okay, class of evidence 2A, ivabradine still comes in. So ivabradine should be considered as an add-on anti-angina therapy in patients with left ventricular systolic dysfunction and inadequate control of symptoms or part of initial therapy. So when we see a patient with heart failure, with left ventricular ejection fraction less than 40 and meets other indications for ivabradine comes in first. Is a class of evidence of 2 to a class of evidence, level of evidence of B, sorry. So nicorandil and trimetazidine is also captured in the ECS guideline, but it's for 3B. So it's nicorandil or trimetazidine should be considered an add-on therapy in patients with inadequate control of symptoms while on treatment with beta blockers, calcium channel blocker, or part of initial treatment with improperly selected patients. So this is class 2B. Class 3, this should not be done. Ivabradine is not recommended as add-on in patients with chronic coronary syndrome when left ventricular ejection fraction is greater than 40% or no clinical heart failure. At this point, this class 3. That means ivabradine should not be used in this class of patients. Also, ivabradine should not be used in combination when there's it should not be a combination of ivabradine with non-dihydropyridine calcium channel blocker or other strong CYP3A inhibitors are not recommended. So that's class 3 evidence B. So in conclusion, next slide, sir. So in conclusion, these novel anti-ischemic agents are second-line medication in the management of stable angina and have been found to reduce frequency of angina episode with minimal effect on blood pressure. They can be used as monotherapy or in combination with beta blockers. The choice of treatment should be individualized and based on the severity of the symptoms, tolerance of therapy and comorbidities, and risk stratification. I think this is the last slide. Thank you.
Thank you very much, Dr. Sar, for such a wonderful presentation delivered with finesse and clarity. We are grateful for the presentation. At this point, we will take contributions and questions from colleagues on the call. And when we are done, we go to our consultants. So please kindly show appreciation to Dr. Sari in the chat box whilst we also unmute to ask our questions, please. Okay, it seems the lecture was very well delivered. So we are not getting questions. So I'll kindly ask our consultants on the call if they have any contribution for us, please. Okay, so Dr. Sari, it appears you've really dotted all the I's and you've crossed all the T's. Thank you. Wonderful presentation. Ivabradine, the acronyms, I'm not good at acronyms and all that, but you made me love the way you simplify this. I think, Charles, yeah, you can unmute and go ahead.
Yeah, thank you. Good evening, everybody. Thank you so much, Dr. Soren. It's a very wonderful presentation. I really learned a lot. And thank you for the many acronyms. It helps things remember. It helps us remember. Thank you so much. Your way of coding it is unique. And I really gained a lot. But I want you to come again with when you were talking about nicorandil, you divided the mechanism of action into two. Please, I'd like you to recap, especially the one that has to do with nitric oxide. I didn't really get that. That's how, because you know the first thing you said is the potassium. Yes, please just recap, especially the two mechanisms of action, especially the nitric oxide one. Okay, that will be through cyclic GMP, but just go ahead and recap. So thank you.
Okay, so as nicorandil, the two mechanisms of action, as you rightly said, is through opening of the ATP sensitive potassium channel. Also, nitric oxide. What nitric oxide does is to vasodilate. So it helps that vasodilate the vessels, and with vasodilating the vessels, it affects both the arterial and the venous circulation. It causes reduction of preload. That's just how it causes its mechanism of action. So not more than what nitric oxide does by causing vasodilation. When it causes vasodilation, what vasodilatation does is to reduce blood flow to that impacted area, reducing the infarct size and also reduction of the end diastolic pressure. So with that, at the end point of everything on reducing the preload in this patient, in this set of patients is to reduce the diastolic wall tension, reduce left ventricular end diastolic pressure, and reduce compromise to those little microvasculations that supply those ischemic regions. So that's how nitric oxide and those vasodilatory effect works.
Thank you so much once again. Thank you.
Thank you very much. In the absence of any other question, we want to say thank you, Dr. Sori. We'll continue to our MCQs. Dr. Charles Okori will share the questions. I'll go off and join soon. Thank you.
Thank you very much, Dr. Yudan, everyone.